Hi, everyone. We're gonna start in a couple minutes, just giving enough time for people to join us from the brunch and taking a quick break from prior sessions. So thank you all for joining. Hi, everyone. As everyone is trickling in, we're just giving a couple minutes for people to join us from prior sessions, and we'll be starting soon. So thank you for joining us. Super excited for this conversation with these two lovely women. All right, I think we are ready to begin. So again, thank you everyone for joining us today for our conference panel, Prescription for Change, Addressing Inequality in Black Health. I'm super excited to welcome here with us today, Stacey Stewart, the CEO of March of Dimes, and Dr. Renee Canady, the CEO of the Michigan Institute of Public Health, as well as an appointed member of the Michigan Coronavirus Task Force on Racial Disparities. So to kick it off, I'm going to give each of you guys a couple minutes to introduce yourselves, tell us a little bit about your backgrounds, how you came to the position you are today. So why don't we start with Stacey?
Sure, great. Thank you, Sandrine. Great to be with everybody. Great to be with Renee as well, and to be at this conference. I am Stacey Stewart, President and CEO of the March of Dimes, and we are the leading national nonprofit fighting for the health of all moms and babies. I am a graduate of Michigan, the Ross School from 1987. I also happen to be former president of the Black Business Students Association. So this is always an honor for me to join with fellow students and alumni and faculty and all of the Michigan family that's here. And before I came to March Dimes, I was U.S. president for United Way, which is the largest nonprofit in the country. I also led our global efforts around education, income, and health at United Way for a number of years. And then before that, I spent 17 years in the mortgage finance industry, half the time at Fannie Mae in the company, and about half the time as president and CEO of the Fannie Mae Foundation, which at the time was the largest affordable housing foundation in the country. And then before that, right after Michigan, I went to Wall Street actually and spent 5 years working in the area of public finance. So I've had a career of working in large institutions with lots of resources, but always doing good and using my business background in education and concentration in finance and all of my experience in banking and business to do good in the world. So hopefully that's what I'm still doing today and will continue to do for the rest of my career. And it's certainly great to be with all of you all.
Yeah, thank you so much, Stacey. Dr. Canady?
Well, thank you all, and thank you for making space for a Spartan in the midst of all these Wolverines. I feel
Always
like
space.
I get a little bit of a pass because one of my sons is a Wolverine. He did the dual engineering program with Michigan and Morehouse, along with his two brothers that did Morehouse College. So I get a little bit of Wolverine clout. And
Yeah.
so I have been honored to be in public health service my entire career. I have a bachelor's in public health nutrition from the University of North Carolina, and actually started my career in the mid 80s in the midst of the AIDS epidemic, when we really did not know what was going on with that public health crises. And so just continued to work in a number of spaces, particularly adolescent health, maternal child health. I served in roles at our state health department, particularly back doing HIV in a collaborative partnership with the Department of Corrections and the Department of Public Health. So really looking at the unique needs of incarcerated individuals. And then shifted my way over to academic public health, and really served initially in the College of Nursing, although I am not a registered nurse. Should have listened to my mom, who was a nurse, tried to get me to go to nursing school, but here I am just doing public health work in spite of that. And served in a number of spaces in sort of recruitment and retention of underrepresented students in nursing, and really then just moved on to continue my education and obtained a PhD in medical sociology, where I really looked at maternal child health, pregnancy experiences across race and class. What are the differences, and why are there differences between the pregnancy experiences for Black women, Black moms, and white moms? And so thought I would retire as a tenured professor at a Big Ten university, and then got recruited back into public health practice to lead the Ingham County Health Department, where I actually began my career in those 1980s. After serving back in public health practice for 7 years, I was recruited to this role, which is a wonderful integration of academic public health, governmental public health, and public health practice. And we are a nationally engaged public health research firm and partner located in Okemos, Michigan, which is right outside of East Lansing. And I've been in that role for 7 years, loving the involvement of multi-sector and cross-sector partnerships. So excited that those of you planning this important conversation as business and future business professionals would think to see the importance of this intersection. So thanks for having me.
Yes, no, thank you guys both for coming. I think just in those introductions, we can see the wealth of knowledge that you guys have, and we're really excited to hear from you and learn from you during this conversation. And I think a really great place to start is just kind of setting the groundwork, right? What is racial disparity? It's something that we hear about all the time. It's almost a buzzword at this point, but what does it mean, and how have we gone from being a country that spends the most on healthcare to simultaneously being a country that has some of the worst outcomes? And then when you add on race and, looking at Black America, how is it that we end up faring even worse than, our counterparts? So Dr. Canady, I'd love to hear from your experience as a public health practitioner, having worked, with incarcerated individuals in nursing schools, trying to increase the representation of underrepresented minorities within medicine. What are some of the main causes of this race gap in outcomes, aside from the racial difficulties we have within the system? What are some other things that you think have really caused this?
Yeah, thanks, Sandrine. Let me first speak to the first point about like what are health disparities and why are we talking about them? And really, it's a mathematical question, right? So if we are seeing African Americans as 25% of the population, which is about what we are in the state of Michigan, but we're seeing amongst disease metrics, African Americans comprising, say, 40 to 50% or higher, then we know that there is a disproportionate disparate representation in disease. And we like to also refer to that as an undue burden of disease. So you would expect 25% of the population should be 25% of the disease prevalence, but we don't see that. And so beginning to look at why that is, and many people want to talk about sort of these personal levels. You've heard probably some absurd quotes by some professionals, some health professionals even, that say, well, Blacks aren't as sanitary, and they don't wash their hands, and they don't, all of these sort of personal behaviors. The clearest reason why we know that African American, this is not about personal decisions, is because we see disparities not only across literally every metric of morbidity and mortality, but we also see disparities across pretty much every sector, including the business sector, right? If you look at, some of you might know the study about the resumes, and those names that were Afrocentrically inclined tended to be less likely to get the interview. So we see disparities in not just unequal interaction, but inequitable. It's not fair, it's not right, it's not just. And I think the fact that we've began framing this as an inequity and allowing ourselves sort of the righteous indignation of, we have to do something about this. It is a moral imperative to shift, not just, yes, give people information and education, but what are the systems and the barriers that are getting in the way of them applying those choices and using their free will. So just wanted to make sure people understand that this is not about equality. It is about equity. What is needed for those people at that time, and how do the systems accommodate that?
Thank you. Stacey, I think, you've spoken to the fact that you've risen through the ranks within business, and you started in finance and then went to the nonprofit space, and now you're at the March of Dimes. And I'm really interested to hear how you see this, play that Dr. Canady is talking about, where there aren't enough of us in the boardroom or even just at the office in general, and how you have tried to mitigate that and work through that. Oh, you're on mute.
Yeah, thank you, but sorry about that.
No
No, it's a great question. Thanks for being, thanks for moderating this, Sandrine. I think this is a great conversation because, we talk about the fact that a lot of the outcomes that we're seeing in maternal and infant health, and of course, we could talk about this writ large across health totally, but my area is really around maternal and infant health, really comes not because of anything that is inherently or genetically wrong with Black people. This comes because of the conditions in which we have lived. I think it's really important to understand this country. Here we are, as you started this conversation, we're the wealthiest country in the world. And among wealthy industrialized countries, we get some of the worst outcomes with respect to health. And it's especially true among Black and brown people. And I think one of the things that's really important now that we're in Black History Month is to really understand our history, that our history is American history. And the fact that in this country, there has never been a time when people, Black people and other people of color, have ever had access to the same high quality, affordable healthcare in this country as compared to whites. If we understand that and know that to be true, and know that that stems even from the times of slavery, after slavery, through Reconstruction, through Jim Crow, there's never been a moment of history and time when we have had access to high quality, affordable healthcare. We should not at all be surprised at the outcomes that we see. There has been a intentional and really deliberate sort of, I wouldn't call it plan, but a set of decisions that have been made along the way to deny Black people, especially, access to the kind of healthcare that could improve our outcomes. Now, having said that, one of the things that we know too is that our health is not really determined mostly by what happens in a doctor's office in a clinical setting.
Hmm.
Most of our health is really determined in how we live, in the communities that we live in, whether or not we have access to healthy and safe communities, whether or not we have access to healthy, safe foods. Do we live without the effects of racism? Do we live without the effects of toxic stress? And if we do, we know that our health outcomes can be made worse. You know, there's a whole concept. Actually, a woman who was a professor at University of Michigan started her work in New Jersey, came up with the idea of weathering. Weathering being for Black women, our outcomes actually deteriorate over the course of our life with respect to birth outcomes because the effects of our lived condition and toxic stress that we experience really as a result mostly of racism and other social determinants of health. So if we know this, then one of the things that we have to do in this country, and there was just a recent study, actually CNN did some work to show, and this was, they reported it, but it was actually a study that was done that showed how much we can actually improve outcomes for babies and even for moms when Black moms and babies are in the care of other doctors who look like them.
Mm.
And that is a very striking sort of study that really helps to underscore that we have racism that has led to the inequities that we see in the system. And that part of how we, not totally, but part of how we can undo some of these inequities in our system is by increasing the number of people who look like the communities that they serve. You know, when we have more Black doctors, more Black nurses, it
Hmm.
doesn't mean that racism goes away in the healthcare industry, but it does mean that we have more people who respond to others who look like them and hopefully do it. And actually, it's been proven that in many cases, we will often get better care. So one of the things that we're really looking at the March Times is one, implicit bias in the system, and obviously advocating for more and more healthcare professionals who look like the communities that they serve.
Yeah. And, I saw that you testified in front of Congress this past January 2020. And a lot of the things that you were advocating for young mothers, I felt would not only benefit Black mothers, but Black families at large. So things such as allowing for longer paternity or maternity leave of 12 weeks or more, giving places to lactate and pump at work, and many things that sound like it's for the mom, but it's really for the community. So, you also speak a lot about how it's an intertwined problem, right? It's not about the babies and infant mortality or maternal mortality. It's such a combined issue. So I'm wondering if you could kind of speak to how those two things are intertwined and how when you address one, you end up addressing a lot of these other issues that we've already kind of touched on.
Yeah, sure. I mean, you know, part of addressing the issues of inequity really have to do with policy change. And that's why we're
Hmm.
so actively involved at the March of Dimes at advocacy and public policy at the federal level and also at the state level. I mean, again, let's compare ourselves to other highly industrialized countries where in many countries you have paid family leave, where midwives are an integral part of the birthing experience, right? Where there's so many other policies that are in place and they get better outcomes. We don't have those same kinds of policies. If a woman is on Medicaid, gets on Medicaid because she's pregnant and maybe she didn't have it before for whatever reason, it's likely that she'll be dropped 60 days after she delivers the baby. But her own healthcare challenges may be extending way beyond that 60 days, and she needs healthcare, but she doesn't have it. Right. So one
Hmm.
of the things we advocate for is extending Medicaid because that helps both the family and the mother. Right. It helps make sure that the mom is there to raise her baby, that the family is intact. You know, we need to expand Medicaid. Where we've expanded Medicaid under the Affordable Care Act, we saw improved conditions and improved outcomes with respect to maternal and infant health. We just simply have to have the public will to do these things. We have to have the will to have paid family leave. During coronavirus, it is essential that people have had the ability to say, I can't be at work because I might get someone else sick, but I can't afford, if I can't afford not to be at work because I can't afford to miss the income, I'm actually going to create more of a public health crisis. So, you know, having paid family leave where we could take care of someone who's sick at home, where we can take time off if we need to, and still not lose income is really super important. That exists in other countries. Again, one of the things that we have to understand is women and moms, are the backbone of our families. When
Mhm.
you invest in mothers, when you invest in women, you are investing in the family, you are investing in the community. And it's not something where there's a cost with no benefit. There's a big, I mean, to speak to business people, there's a significant ROI when we invest in communities and in
Mhm.
families and in women and our health and our babies, our future generations to lead and to be there to be productive citizens in the world. So as a country, we have to come to a conclusion and a decision at some point that we can't shortchange our people and expect that America can continue to be a strong, productive, competitive country. If we don't invest in our people, we will see failed results as we have seen in the past.
Yeah, I think that's a great point. And, you bring up the topic of COVID. We've obviously seen the disproportionate effect it has had on our communities. Then we look at the COVID vaccine rollout, which again is not going as well as we had hoped. And again, we end up having, if we are 20% of a working force, maybe 3% of Black people have been vaccinated in that same area. So, Dr. Kennedy, I want to kind of turn to you for this as a member of the Michigan COVID Task Force on Racial Disparities. How has the task force been trying to mobilize and increase the rates of Black individuals in the community becoming vaccinated?
Yeah, let me give a contextual comment and
Yes.
work my way into that question, because I really just
Yeah.
want to underscore a point that Stacey made about um, what we in public health call racial concordance from patient to provider.
Mm,
Are your providers looking like you, similar to your culture? That's so vital. And I would submit that providers and clinicians of color have an additional burden because they're bringing in their identity of who they are, but they're also being socialized in, if I can simply say, a culture that was framed in white supremacist values. So even though they're coming in with all their true identity, they're getting taught, do it this way, think about it this way, no, reframe it that way. And so there's like this tension, what we call in sociology effortful coping, of how do you stay true to that while the standards are not really accommodating who you are and who your patients are. And so we see clinicians experiencing the same level of trauma, same types of trauma, particularly in a pandemic, that their patients are experiencing. And so I just want to underscore how the system is doing what it was designed to do. And when Stacey talks about policy change and how we have to be motivated to shift those things, it's vitally important. The challenge is at this point, the people who hold the power don't really have the motivation to change. Like, it's working well for them. Why
mhm.
wouldn't it change? And why don't y'all Black and brown people just get on board? And so it's a complex circumstance. And so I do commend our governor for early in this pandemic recognizing, yep, Black, brown people are experiencing this pandemic very differently than white Michiganders, as she likes to say regularly. So that context in setting up a task force, not just a broad COVID task force, but we set up a coronavirus task force on racial disparities to bring a level of intentionality to how are we driving change. And we got started in March and
Mhm.
met literally every Friday. Every Friday. What a sacrifice since since last March, right? Grappling, talking to each other, having work groups where we break out, looking at primary care. What are the issues and the barriers in primary care? Not just that person, but the system. What can we do to make the healthy choice, the easy choice, the healthiest choice, the easiest choice for African Americans, and particularly in Michigan, concern for Indigenous communities, Native Americans in our state. And so we have seen that bringing that level of intentionality around social distancing, personal protective equipment, all of the things that we needed pre-vaccination, that we began to see the ratio of rates of infection per million people, lovely little epidemiological pattern, that when we looked at April and March, down to September and October, we went from about 270 lives per million to 1 life per million amongst African Americans. So we know that system change can be effective. It's the point that Stacey's making. Do we have the will to persist and sustain? Because we're really good at starting new programs, and then, the grant ends or whatever, it goes, the headlines change, and then we just spiral back to our past bad habits. And so we know that change can happen if we're committed to it.
Yeah. And I think that something that comes to mind for me when I think about vaccination is trust, right? We want to trust that when we're told that a vaccine is going to protect us, that it really will, that, efficacy, you see 96% for one vaccine, 66% for another. How do we bridge those trust gaps that we have, especially within the Black community, not only in, the medical institution, but in the idea that this vaccine that is being presented to us is really going to do us more positive things than negative, right? Because I think, and I'm sure some of my classmates can agree, we've been in chat rooms or we've seen discussions or we've talked to family and they're like, I don't want to take this vaccine. I don't know what this is. Like, you hear a lot of different narratives. So I'm interested to see how, from both of your perspectives, how we can start to bridge that gap and really get people trusting in the institution again. And Renee, if you could start.
First of all, I've as of late been really pushing back against the problematization of African Americans. Like right now, Black people don't trust the government. Black people
Agreed.
Don't trust. Well, we have legitimate reasons not to trust the government. But I also want to say that white folk don't trust the government either. So go out and talk about them. What do you think that insurgents on the Capitol was about? It was about white people who didn't trust government. And so I'm just always cautious that people don't center the problem with us. The solutions to building trust in African American communities will likely look very different than the solutions to building trust in white communities. But the other thing that I want to just offer is the hesitance that many people are expressing is a common phenomenon that we see in pretty much all health behaviors. We talk about sort of early adopters, the movable middle, and those sort of resistant, it's like that bell curve, right?
Yep, the adoption curve.
Right, absolutely.
Yes.
And there are those folk that are going to be standing in line for 2 days to get the new iPad. When the iPhone 20 comes out, they're going to be right there getting it. Other people are going to say, I'm gonna wait. They're going to let them get the kinks figured out of that. So there is some natural inherent tendencies that we have individually around risk taking. And so I want to honor that. And in public health, what we've been trying to do is meet people at the point of their need. What is the particular concern that individuals are having, and how can we attend to that? And I'll confess that, even my colleagues had to sort of go through, we were back and forth on, well, which study did you read and what are you looking at? So we went through our own processes to get to a place of confidence. And so even when we see, and as we've seen, African-American clinicians getting the shots, getting the vaccines, recognize that they themselves had to go through a learning and an information process to get to that point. And so we want to make sure that information is accessible. We're in public health doing a lot of these sort of mass vaccination clinics. at, I forgot what Cobo Hall is now called, TCF, or it's got another name, forgive me. But sometimes doing mass vaccines is not the accessible way for members of our community. You know, like I got to get on the bus line, then I got to get right way over there. And so I do think we have to begin to think outside of what's the fastest way to get shots in arms. I was on a meeting earlier today and talking with colleagues who have been engaged in vaccine clinics, these mass clinics. This was a group of African-American women, and they expressed concern that not just in Michigan, but somewhere in Ohio and somewhere in West Virginia. And they're saying, you know, probably 5% of the people I'm seeing come through are Black, and it's really concerning. It's mostly white folk jumping in, taking advantage of even the efforts to make it accessible to underrepresented communities. And so there's no easy switch, right? Some of us have to be doing intentional education from reliable sources, from trusted voices, and others of us have to be thinking about the logistics and the pragmatic side of this, and how are we going to effectively get vaccine out to individuals. But I think if you're feeling hesitant, be true to that feeling and be open to learning more so that you can make a well-informed decision for yourself and for others.
Yeah. And Stacey, I know that you had brought up before, you know, March of Dimes involvement in creating the polio vaccine and how that has been very, you know, informative for you on how we can bring in and really show that Black people are not always on the outside of advancement, but also a part of it and an active member in creating that. And that's not really a narrative that we hear often enough. So I'd really love to hear your perspective on that as well.
Yeah, I mean, I think I agree with Renee. I mean, there are a lot of legitimate reasons for Black people to have a lot of distrust of the medical system. As we just mentioned, over history, time and time again, we've been affected, negatively affected, sometimes fatally so, by the system. A lot of people like to recall the Tuskegee experiment. We know about the stories of Henrietta Lacks. But there are other stories out there that really show that there have been moments in history when Black people have actually benefited greatly from medical advances and have actually been included in them. One of the things that I had a chance to really do when I started the March of Dimes was really dig deeper into our own history of the March of Dimes, and was really so excited to learn more about the history of our history and the polio vaccine. How much the March of Dimes partnered with Tuskegee Institute. Many of the data scientists at Tuskegee were a part of the research that contributed and supported Dr. Salk's work, leading to the discovery of the polio vaccine. There were many Black people that were included in the initial clinical trials for the polio vaccine. This is during a time of segregation when Black people were not included in anything like this. There was a deliberate, intentional effort to make sure that if there were going to be clinical trials, that Black people would have access to it. That gave us the confidence to know that the polio vaccine would be effective across all populations. That was really important. I've actually met people, Black men from Alpha Phi Alpha, who were part of those clinical trials. The March of Dimes developed many of those relationships with Alpha and the Zetas and many other fraternities and sororities in order to ensure that the polio vaccine would be distributed equally and fairly throughout once it became approved. And, we know about the history of J. Marion Sims, for example, the father of gynecology, who experimented without anesthesia on enslaved women. We know we have a very painful history when we look at the way medicine and the medical field has treated Black bodies or not treated us. And so we got that. We know the history, but this is what we're saying. And I think Renee said it so well. If you have hesitancy or if you're feeling uncomfortable, talk to an informed provider. When my daughters had to get the HPV vaccine, and there was by law a requirement, I was hugely hesitant. I had a lot of concerns about it. Well, what did I do? I went to their Black pediatrician. I talked to my Black OBGYN. I trusted, as I had always trusted my life, the life of my children. I put their, our care into their hands. I trusted their opinion. I trusted their review of the science. And when my pediatrician said, yes, it's safe and you have to do it and you should do it, we did it. And so it's nothing wrong with having this idea that I have to become more educated and informed. We all should. And I encourage everyone to take their own path on that. At the same time, though, we are at greater risk of severe illness. Pregnant women, if we get coronavirus, pregnant women are at greater risk of a severe illness if they contract the virus. We know this. We know that Black people in general and people of color are facing some very dire consequences if we contract coronavirus. So the options are go to a vaccine that has been studied, reviewed by multiple people and been proven in science, or stay at risk with a virus that has the potential. And now with these new variants, we're not sure exactly how it's all going to unfold with us. We've got to make the decision to do what's in the best interest of the entire population, but also what's in the best interest of ourselves and our families. And that is something that, again, with the review of science, with our ability to be more transparent with data, we have the ability to rely on our own trusted advisors and ourselves to be what better informed, but make the good decisions for our own health. And that's really important.
Yes,
Let me give
definitely.
it. Let me give an example. So this is just occurring to me listening to you, Stacey. We know that Black babies are 2 to 4 times as likely to die before their first birthday because of complications in pregnancy. That does not stop Black women from getting pregnant. We are making an informed decision. We're thinking about how likely will that negative outcome occur to me? How severe might the outcome be? What are my beliefs about the benefits and the pros and cons of pregnancy? We go through those decisions. And so this is in some ways, very similar, right? You're thinking about what are the
Exactly.
benefits to my getting this vaccination? What would be the likelihood or the severity if I don't? And all of those things. The challenge with this vaccine, because this virus, because it's new, a novel virus, the outcomes are so unpredictable. Like we're seeing 20-year-old, otherwise healthy young adults dying because of COVID. And so that predictive reliability is not quite as high if you're going to take a chance with your health and well-being. And so we absolutely believe that the benefits of vaccination far outweigh the risk to not being vaccinated.
Thank you. And, I think throughout this discussion, we've talked a lot about women, right? Women being the backbone of their communities and really paving the way for health and wellness within the family. But I want to talk about men a little bit, and how can we bring them into this fight and really have them take a bit, maybe more ownership in not only their own health, but also in the health of communities, to make sure that there isn't an undue burden on women themselves, but also that we're motivating men to really be a part of the solution as well. Stacey, I'd love to hear your thoughts.
Yeah, no, it's a great question. So one that, we at the March Times, obviously we focus on healthy moms, strong babies, but we actively involve men in the conversation because there are a lot of studies that show even some birth outcomes are even determined by the health of the dad. So it's not as if the mom alone is solely responsible for ensuring a healthy pregnancy and a healthy baby. The dad's health is also really important as well. We just recently started a partnership with Kappa Alpha Psi, and as I mentioned, we've had a long partnership with Alpha Phi Alpha, and they have been really actively involved in promoting fatherhood and understanding the role that Black men play in ensuring the health of a family. I don't know what the numbers look like in terms of vaccine hesitancy, for example, but I suspect that there's, and Renee, you probably know better, but we have to do a lot more to make sure that our men are taking their own health in their own hands. One of the things that we do at the March Now is make sure that everybody sees the health of the community as really important, but also that, especially as people of color, as Black people, that we understand how to become better advocates of our own health. Nobody is a better advocate of our health than we are ourselves. And so the more and more we become informed and educated and can engage, everyone in this conversation about what's in the best interest of the health of our communities and of our families, we have to make sure it's not just for us, not just women that are involved in that, but also men who are a critical part of that. And we don't think that we'll be able to improve health outcomes overall, especially in Black and Brown communities, without engaging men in the conversation and empowering them to really see their role as critically important.
Renee, what are your thoughts?
Kaiser Permanente did a study, and actually when they looked at vaccine hesitance across gender, it was pretty equal, about 2% off. So men were hesitant and women were hesitant. It wasn't really predicted by gender. But we also know, as Stacey said, that if we look at maternal child health outcomes, pregnancy outcomes for Black women are much stronger when the father of the child is engaged. We know that. And so I tend to think that those types of patterns tend to be replicable across other health metrics, right? I haven't seen any studies, but I would imagine that if you have a woman fighting breast cancer and her social support involves her significant other, her husband, or whoever it would be, those outcomes are going to be better. And so, as I said at the beginning, this need for intentionality, we, for as an example, at MPHI, where I presently serve, we shifted our maternity leave to a parental leave. Initially, they had sort of a paternity leave. And so we just, started talking about that. Why we thought that was so progressive. Oh, we have maternity leave and we have paternity leave. Aren't we great? Well, why are we delineating that? Let's think about what families need. And so we've shifted now to a model of paternity leave. And it is 8 weeks for a dad or a mom with pay. That was a policy decision that we made at our level. But then how do we use that power and that influence to push in other systems to say, I haven't lost any revenue. Our performance has not dropped because we're honoring this significant family event and treating it as a family event. So kind of courageous decision-making, I would submit, is what's called for right now.
And in some ways, you're probably increasing your bottom line, right? What is the difference between the mom being sleepless and the dad being sleepless? They're both going to come to work and fall asleep at their desk. So might as well give them a couple of weeks to just get through the first 2 months and get into that pattern. And I'd love to invite the audience now to, raise your hand if you have any questions that you have for our panelists, and I'll unmute you and you can ask away. But, oh, excellent. We already have one. Brittany Banks, go ahead.
Yes. Hi, everyone. Thank you so much for hosting this panel. I'm loving every moment of it. My name is Brittany Banks. I'm a first-year MBA student at Ross studying healthcare management. We're seeing a shift in medical care to an adoption of precision medicine and leveraging genomic data to develop individualized treatments. However, much of this data doesn't actually include diverse data points due to lack of participation in clinical trials, among other factors. So my fear is that we're actually being left out of some of these medical advancements, but I would love to hear your thoughts. Where do you see this shift kind of taking Black health and health equity?
Thanks, Brittany.
Great question. Great question. I'll throw in some 2 cents and then defer to Stacey. There is a national initiative called All In, where they are trying to really gather this database of genomic samples to study varying presentations of diseases. And so, MPHI has been involved in some recruitment efforts in that regard. It is really, really important that we have presence. It's a little bit of a conundrum, right? We're not sure we trust, so we don't want to be involved in studies. But if we're not involved in studies, then we probably can't trust the outcomes of those studies. Presence and inclusion is really, really important. And so just, kind of nudging ourselves, being accountable to each other and say, hey, do you know about this genomic study? This study is especially important because we're talking a lot also about the field of epigenetics, which is sort of the social impact, the impact that our environment has on the manifestation, the gene expressions in our bodies. And we know that our environments can be way more stressful for a variety of reasons than our white peers, our white colleagues. And so our presence in these studies, many of which are very benign, right? It's not taking a lot to be a part of these studies, is critically important. And I'm optimistic about the findings that we'll see down the road.
Yeah, I would just say that, at the March Times, we're taking an approach right now to leverage some partnerships so that we can use better data for predictive purposes around managing the issues around maternal and infant health, especially at a community level. But I would say, in terms of this more individualized health issue and how we get more Black people to participate in the kinds of new technologies and the kinds of studies that will allow us individually to better understand our own health, manage our own health, it's going to take, I think, a massive campaign to really help all people understand, especially us, why it is so important for us to be a part of the next generation of healthcare and how we can be a part of helping companies that are really involved in this to include us more in the studies and be a part of the studies. The same hesitancy we've been talking about that's keeping us from accessing the vaccine, it's the same hesitancy that's going to keep us from out of a lot of these studies and not a part of it. And when the solutions are built, they won't necessarily always fit for us because we will not have been a part of those studies. So I think a lot of it is going to have to come if we have the level of, and maybe we can see this under a new Biden administration with a new Secretary of HHS and other leaders, both in the government and outside the government, who can continue to talk to Black people about how to engage in their healthcare in ways that recognize the way we've traditionally provided care is really changing rapidly. The data collection and the data analysis that is going on that we've never had before is really what we've got to be involved in to help us better manage our health over a long period of time. And we have, as Black people, facing, a whole range of chronic health conditions. The issues around maternal health are largely impacted by heart health, right? The fact that 1 in 3 maternal deaths really comes and stems from the issues around heart disease and heart conditions is really because overall our health condition is not where it should be. And so the kind of education we need to do, maybe the kind of leaders that were graduated from Ross can really help us get to a new generation of what does it look like to be a part of a more sophisticated medical care system as we move forward. And we, of all people, need to be a part of that and be better informed and educated about it.
Thank you. That was a great question, Brittany. All right, next we have Sean. Go ahead.
Hello, can you hear me?
Yep, we can hear you.
Yes.
Oh, great. Well, thank you, ladies, for taking time out of what was, I'm sure, a busy Saturday afternoon to help educate us. I really appreciate that very much. And, I graduated from medical school back in 1992, where no one really even knew what DEI was. And, the implicit racial biases that we see physicians of all races having, while it's unacceptable, it's almost not surprising in the sense that from day one of medical school, we're taught, what diseases are more common in Blacks, what diseases are more common in whites. And even the first few words that we use to describe a patient to another colleague is, I have a 55-year-old African-American woman, for example. So given what we know to be implicit racial bias amongst healthcare providers, what role do y'all see for either initiating, if there is none, or expanding, if there is some, DEI training in medical schools?
Sean, thank you. That is such an important question. Our governor in Michigan actually just passed legislation that in order to renew your license, you have to present evidence that you've done some type of implicit bias training. Now, I would submit that is the very first step, because knowing a thing and integrating that knowledge so that it shifts your actions are two completely different things. And so I think that I love that example that yes, we present. I'm my patient is a 55-year-old Black man or whatever. The problem is not that we present that. The problem is, how do we receive it and why do we receive it? If we receive it as, if I'm a white clinician and I hear the patient is Black, that should put a check on me to elevate how I'm thinking about how culture might come into play. If I'm a Black patient and a Black provider and the patient is Asian, I've got to be thinking about how can I leverage culture and difference to be a strength in engaging in that clinical encounter. So, I'm appreciative of the governor's first step. And every opportunity I have, I say, this is the first step. And then we'll begin to push. How do we now shift to curriculum? And what are we teaching differently? As I mentioned, many medical schools and public health schools and nursing schools are still using a curriculum that really is based in a white supremacist or white culture priorities. So how do we shift and integrate and expand the context of those? I teach a course in our MPH program on applying principles of equity in public health practice, but it's one course, right? That's not going to undo all of the learning passively and directly that students get living in this society. So continuing to have the conversations that you've introduced with this question, I think are especially important.
Yeah, and I would just add to that, 2 years ago, we launched at the March of Dimes our own implicit bias training program, specifically targeting healthcare providers. We've trained about 10,000 healthcare providers now on recognizing and taking action on their own implicit bias. But I agree with Renee, just taking an implicit bias course is just the first step of probably beginning to undo probably years and years of training that has been based on really incorrect thinking and really dangerous thinking that really plays out in terms of how Black people get treated and the disparate treatment of Black people in the healthcare system. I'm thrilled about what Michigan is doing. California did something similar, which, passing a legislation that requires healthcare professionals to engage in an implicit bias course. We know that in Congress, and then Senator Kamala Harris, now Vice President, was very involved in introducing legislation in the Senate that would actually include in medical schools, in training. We hope this gets passed. We're certainly pushing this hard at the March of Dimes to make sure that there is a change in the curriculum in medical schools with the training of all healthcare professionals to recognize implicit bias and to undo some of the really dangerous teaching and thinking that has been perpetrated in medical schools for many, many years. The way healthcare professionals are often taught that Black people don't experience pain in the same way. Right. Which stems, we know, from a time of slavery, right? These are things that have really perpetuated over many, generations, over, hundreds of years. There's a lot of thinking that we have to undo. And I agree, when you acknowledge that your patient is Black, that is a good thing. But when you don't respond to a patient who is Black and recognize the kinds of life conditions that patient may have experienced, and therefore her health outcomes and her treatment plan may have to be different to acknowledge that she may be in a different situation from a health perspective. When we look at the issue, that's where we've got to get to. The CDC even has said, even among maternal deaths, 60%, maybe 2/3 of them are preventable if we have healthcare providers who just respond to women in the ways that will keep them healthy and keep them living. If they recognize and diagnose and come up with a good treatment plan, if they don't delay diagnoses, if they recognize and don't dismiss if a woman says she's in pain or she's got complications, respond to her when she says that. Listen to what she's saying. Respect that she's coming forward with some legitimate symptoms. Don't dismiss her because you think because she's, you know, a certain kind of woman, a Black woman, that her you know, what she's expressing needs to be diminished. So again, we've got to do a lot more in the healthcare field in total, with medical providers, with doctors, nurses, and others, to train them differently on every patient's not the same. And we've got to make sure that if we have these inequities that we're seeing, that means we may need to do more and do things differently to make sure that we don't have Black women who die at a rate of 3 to 4 times that of white women just because they were pregnant and gave birth to a child.
The gold standard has always been, I treat all my patients the same. Well, shame on you, because all
Right.
your patients are not the same.
They're not the
So
same. That's right.
if you can do anything,
Yeah.
push against that mantra. Well, the right thing to do is to treat everyone the same. Mm-mm.
Yes. Right.
Nope. Definitely.
Thanks,
Thank
Sean.
you. That was such a great question, Sean. So with our last 5 minutes, I want to give each of our panelists a chance to tell us, what is your throw down the gauntlet challenge for our audience today? What is something that you want them to really take away from this discussion and move forward with to kind of help create that change that we're looking for? I think that COVID has brought an even greater spotlight on what racial inequality looks like in medicine, and maybe has even provided us with an opportunity to really push things forward in a way that we didn't have before. So what would be your challenge for our audience today? Renee?
Well, I have so many gauntlets to throw down. Let's see. I'm going to throw down the be a risk taker right now. You are in a very small percentage still of our population of African Americans who actually have the honor and the privilege of attending graduate school. So if you hold an advanced degree as an African American person, to whom much is given, much is required. And I was looking at risk taking, and people oftentimes don't take risks. And speaking up when you may be the lone voice is taking a risk. And we don't do that because we're afraid that something will go wrong. And then we're afraid that if it goes wrong, we won't have the ability to handle it. Well, you do have the capacity to handle it. You are well abled. And minimizing the consequences of inaction are even worse. For us to sit silently means that more babies will die, more seniors will die of COVID, that all of these mortality and morbidity measures will become self-fulfilling prophecies. You are the people for such a time as this. And I want to thank you for being courageous leaders and not just cautious or cowardly leaders.
Thank you. Thank you. Stacey?
Yeah, I think that's great. You know, it is Black History Month. And one of the things that Dr. King said is, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And, you know, I think a lot of us know Dr. King's work because of what he did in civil rights, what he did to bring economic rights to Black people, to create enormous change. And that statement about the inequity in healthcare, I think, is one that we forget that Dr. King cared about deeply and was as concerned with. You know, one of the ironic things about me even leading organizations focused on public health, though I didn't come through the training that Dr. Canady did, I served on the board of Grady Hospital in Atlanta, Georgia, where I'm from originally, for 7 years. I wasn't on the medical side of things. I chaired the finance committee of all things. Surprise, surprise. But it was the largest public hospital in the Southeast, and I became deeply involved in public health issues. But several decades before that, my father had helped, was a physician and helped desegregate Grady in the 1960s after the Civil Rights Act was passed, and worked with President Johnson. It's ironic to me too that after so many years of us fighting these fights, we are still fighting the good fight. And I think it is important. I would just agree with Renee in saying that just because you are in looking to pursue a business career or have gone to business school or in business school right now doesn't mean that you can't emerge from that using your experience to not only succeed in your career, but to do something good for others and to contribute back to your community. In fact, you have an obligation to do that. And I agree with Renee very much. There is no sitting by the sideline and hoping that someone else is going to fix these problems. That has been entrusted to us and to you. And so, whatever you're doing in your career, whatever you're thinking about in your future, think about what you can do to deal with some of these inequities. I thought Brittany's comments were amazing, thinking about, how her career and her training is going to help us deal with precision medicine and accessing it, getting Black people to be able to access it down the road. Beautiful. That may not be the path for everybody, but certainly each one of us has a responsibility and obligation and a duty to figure out how we can improve our communities. And that's the gauntlet that I'm going to throw down for everybody today. And it's really a pleasure to be here. And thanks for inviting me to be with you all at this conference, which is so important to me and has been for a long time in my life. So thanks.
Thank you both so much for coming, speaking with us, having this important discussion. As we've heard from both these women, as well as Angela Rye yesterday, it's important for us to be risk takers and really take our positions with pride and make sure that we're bringing about the change that we know is oh so needed in our society and in our world. So thank you again. Have a great rest of your Saturday and a great rest of ALE. And we will see you all again. Thank you.
Thank you. Take care. Bye-bye.
Bye.
They picked a service project, and it's March of Dimes, and this lady's the